I'm very excited to be welcoming our first speaker, Dr. Susan Wilcox. She's the Chief of the Division of Critical Care, as well as the Vice Chair for Clinical Affairs within the Department of Emergency Medicine at Massachusetts General Hospital. She has special interests in mechanical ventilation, pulmonary hypertension, and critical care transport. But today, she's going to be sharing her expertise with us on her approach to cardiogenic shock. Dr. Wilcox.
Hi, everyone. Thank you so much for having me. I'm really honored to be here. All right. So since I know I'm not supposed to ask, I'll just assume. All right. So as you heard, I'm going to be talking about cardiogenic shock. I have no disclosures. So the first thing I want to start with is describe what is cardiogenic shock. What am I saying when I'm talking about cardiogenic shock? I want to emphasize that we see a lot of heart failure in the emergency department. And heart failure really means that we have a patient who's got ineffective cardiac function for whatever reason. In many instances, it's because they have a decrease in their contractile function, but it can be due to diastolic dysfunction, valvular disease, a whole host of different things. But when we have heart failure that transitions into the patient not receiving enough oxygen to their peripheral tissues, that's shock. And I think it's really important in the emergency department that when we have a patient who has shock from cardiac dysfunction, we label it as such, because it's so critical that we understand what we're dealing with, because calling cardiogenic shock heart failure, it undermines the importance of the issue. Cardiogenic shock is not a common cause of shock in the emergency department. This graph here, these graphics are based upon data that I took from a European emergency medicine study. And I think that it probably overrepresents the amount of cardiogenic shock that we see in our emergency departments. It's actually very rare that we see cardiogenic shock in the ED. However, it has an extremely high mortality rate, even in this day and age. The mortality rate for cardiogenic shock is somewhere in the 40 to 60% range, depending upon etiology, comorbidity, and such. And so it's so critical that we label it as cardiogenic shock, recognize what we're dealing with, and intervene appropriately. Lots of different things can cause cardiogenic shock. The most important one for us to know in the emergency department is, of course, ischemic causes. This is the most common cause, and it's the most critical one for us to intervene upon. So this can be STEMIs, but it can also happen with patients who are having non-STEMIs. Other things to think about are the post-MI complications, which thankfully don't occur that much anymore due to common cardiology practices, thankfully, but they do present to the emergency department on occasion. Patients who come in, had a STEMI, and then 48 hours to even a week later, they come back with their mechanical complication. A more common cause of cardiogenic shock in the ED is actually the patient who has chronic cardiomyopathy. And it's that patient who's been kind of going along okay, and then something tips them over. And their causes of cardiomyopathy can be due to ischemic disease, say like they had an MI years ago, or idiopathic cardiomyopathies, previous viral cardiomyopathies, all sorts of different things can cause it. But yes, something usually tips them over, and then they come into the emergency department in shock. Stress cardiomyopathy is also known as Takotsubo's. It's not an infrequent cause of cardiogenic shock in the ED. Myocarditis, again, we've been thinking about that a lot over the last year. It's certainly been something that's at the forefront of our minds with COVID, but other things besides viral myocarditis can cause myocarditis, and it does cause cardiogenic shock. Patients with valvular disease can be kind of like the patients with chronic cardiomyopathy. They can be going along okay, and then something tips them over. And I keep emphasizing the something because it's often arrhythmias. Arrhythmias are very unlikely to be a primary cause of cardiomyopathy in a patient who's got an otherwise normal heart. However, they can be the thing that tips these patients over or exacerbates the cardiogenic shock from all of these other different etiologies. So arrhythmias are still very important in the management of cardiogenic shock patients. And over to the side, you see I've got here left ventricle, right ventricle, and biventricular failure. So this is important, and I know you're about to get a talk on right ventricular failure in and of itself, so I'm not going to belabor that too much. But it is helpful to think, are we having a right-sided problem, a left-sided problem, or a biventricular problem? Because we've for so long thought about the heart as just really being the left ventricle, and it's not. And so having an idea of where the problem lies helps us manage the patient more effectively. Cardiogenic shock is not always easy to recognize. Now, when a patient comes in with a history of like chest pain, shortness of breath, clutching their chest, and they're in extremis, those are pretty easy to recognize. But unfortunately, I guess maybe fortunately for the patients, unfortunately for us, patients don't always present with such a clear-cut presentation. And so they might come in and they're just feeling unwell, but they're cold, they're clamped down, they're mottled. And I have a picture here of a young man who had viral myocarditis from flu B, and you can see his foot. It's blue, it's purple, it's clearly being poorly perfused. We've got a bear hugger on trying to keep him warm. And sometimes people blame my beloved pressors for this. This patient was not on pressors. This is not due to pressors. This is the patient's intrinsic compensatory mechanism for trying to maintain his cardiac output. And so he squeezes down, his blood vessels squeeze down to try to maintain the blood pressure and maintain his cardiac output. And another way this manifests is low pulse pressure or a narrow pulse pressure. You can see that image that I have there of a patient's screen in the CCU, 82 over 72. That's a very narrow pulse pressure. Sometimes it's not quite so obvious, but when you see that, that's an indicator that there could be a cardiogenic cause of shock. You know, if a patient comes in and they're in shock and they have an elevated JVP or pulmonary edema, that's also a nice marker that this could be cardiogenic in nature. And an important thing to remember in cardiogenic shock is that the patient's not always hypotensive. So, you know, we often think about shock equals hypotension, but not always. Remember, it's ineffective oxygen delivery, ineffective blood flow. And so if the patient's not getting enough blood flow because they're clamped down, their blood pressure might be okay for a while, but they're still in shock. You know, if a patient has EKG changes, they have a STEMI, their extremis, these again are very easy patients to recognize, but their EKG changes might be more subtle. And that's why it's important for us to keep cardiogenic shock at the forefront of our minds when we're examining these patients. And this is the EKG for the young man whose foot I showed you, the viral myocarditis. I know no one would have any problem recognizing that this person is in cardiogenic shock. This is easy, but again, they're not always so straightforward. This is where ultrasound comes in. You know, I'm speaking to a group of emergency physicians, and this has really become our wheelhouse. We are experts at the bedside cardiac ultrasound, and it's such an invaluable skill in examining these patients. Not only does it help us point towards cardiogenic causes as opposed to distributive or other causes of shock, but when I was talking before about left and right ventricle, it helps us actually start to delineate which side is the problem, or if both are the problem. So when you see an image like this patient with these massive atria, it kind of tells you that there's something chronic going on, and this can be an important clue to what's causing the patient's cardiogenic shock. I could do a whole hour talking about the pros and cons of different methods of assessing volume responsiveness, if we should actually be using the term volume tolerance, which is a term that I really like, talking about the limitations and the benefits of ultrasound for this, because there's a lot of data, a lot of thoughts, and I only have a couple minutes. What I'll say is that I look at it as a data point. There are some significant limitations, but if we have a patient who's in shock and we look and we see a plethoric IVC, that at least is a data point. It helps us get a little bit of a sense of what's going on. And so it's not the end all be all for determining volume responsiveness in all scenarios. And so I'm not trying to make that argument, but again, I encourage people to look at it because it is a data point, and taken in context, it can be helpful. Once we've determined that the patient's in cardiogenic shock, it's really helpful to determine if they are having an ischemic cause. And so looking at the EKG, thinking about ischemia as an etiology is so critical, because this is where, as emergency physicians, we have to intervene. So I have my cartoon here of the heart, and I have this, LAD having a lesion here. This illustrates why it's so critical. So this LAD has a lesion, and we have decreased blood flow. Makes sense? We start to get an area of ischemia, and the next thing that happens is we start to lose cardiac output. Now, these arrows represent what we would expect for normal contractility. The black arrows are showing normal contractility, and the red arrows are showing us normal cardiac output. But in the setting of ischemia, now we have decreased contractility, decreased cardiac output. That's all intuitive. But the thing that people sometimes forget about is that if the blood's not going out, it's got to be somewhere. And so it's often just sitting there in the ventricle. And what that means is it's increasing the wall tension inside that ventricle. So now you've got two additional problems. You already had a lesion there in the coronary artery, so you have decreased blood flow. Now you've got decreased cardiac output because you're not putting as much blood down through that already narrowed or completely occluded, that's a problem, artery. But then also, if you've got that increased wall tension, you can imagine that's going to further decrease any blood flow as you've got the increased wall tension, and so other collateralization is going to be minimized, and it's just going to be creating a downward spiral. And that's why it's so critical that we intervene as soon as possible. And we aren't doing the cardiac catheterizations, but it's our job to recognize these patients and get them where they need to be. So we want to open up that blood vessel, minimize that ischemic time, and try to restore their normal cardiac output. It's the most important thing we can do when a patient presents with cardiogenic shock due to ischemia. And so when we think about the rest of managing these patients with cardiogenic shock, we always talk about airway, breathing, and circulation as our resuscitative goals. And in cardiogenic shock, I really argue that it's better to think about preload, contractility, and afterload. So when we're thinking about preload, unless the patient is grossly volume overloaded, the American Heart Association recommends starting with small boluses. Now, if that patient is a chronic cardiac patient, a chronic cardiomyopathy, they might well be volume overloaded. But if they're not, it's reasonable to start with a small bolus. But remember, if they are one of those patients, they might benefit from diuresis. So I have this X-ray here showing, this is a patient that I have in the CCU who has a lot going on. This is a patient who needs diuresis, not more volume. We want to move very quickly to vasopressors and inotropes. And I would also encourage you, just like using heart failure and cardiogenic shock appropriately, if you can use vasopressors and inotropes appropriately, it adds a level of sophistication to your discussion about managing these patients. So the drugs that we're going to use for cardiogenic shock are, thankfully, ones that we use all the time. Norepinephrine is our first line agent. We're all very comfortable with norepinephrine. We know how to use it. That's the good news. Vasopressin can be very useful. If a patient is really tachycardic or they're in that vasoplegic stage, they've gone from their squeeze down and now they're starting to vasodilate, vasopressin can be helpful. It doesn't act on the pulmonary vasculature, so that can make it useful in the settings of biventricular failure or right ventricular failure. Now, dobutamine is a drug that we don't use very much. And I think part of the concern is that dobutamine is a vasodilator. Dobutamine causes a decrease in your systemic vascular resistance while it increases contractility. And so we don't use it as much in the emergency department, but I do think in these particular patients, there's a role for dobutamine. Epinephrine used to be one of the first line agents, but there have been some recent studies that indicate that epinephrine may be associated with some worse outcomes in patients who have cardiogenic shock. And so it's really fallen from being a frontline agent more to a later, like a second, third, or fourth line agent in cardiogenic shock. So putting this all together, here's my algorithm for managing cardiogenic shock with regards to vasopressors and inotropes. Cardiogenic shock patient who's hypotensive, start with norepinephrine. If they're vasoplegic or very tachycardic, you can start with vasopressin. If you've given them norepinephrine and they're hypotensive or they're getting too tachycardic, then you go on to add vasopressin. If they have poor perfusion, they're in that clamp down phase, but they're not yet hypotensive, then you can start with dobutamine. And if you've given them norepinephrine, vasopressin, and they're still poorly perfused, think about that foot I showed you, they're cold and clammy, then you can add dobutamine on top of it. But dobutamine can cause hypotension. So if they start to get hypotensive, go back up to the top and increase your norepinephrine or add the norepinephrine if you didn't already have it on board. If the patient has bradycardia, they have one of those arrhythmias that's then causing them to tip over. So if they have bradycardia causing shock, in that case, it's probably reasonable to start with epinephrine as your first line agent. But otherwise, I would recommend that you go through the rest of this algorithm. And if the patient's still hypotensive or hypoperfused, then it's appropriate to add epinephrine at that point. The last thing I want to talk about is afterload. And the major cause of afterload that we have in the emergency department is positive pressure ventilation. And again, I'm not going to belabor the right heart too much, but it's helpful to think about the right heart and the left heart as being different because they have different responses to positive pressure ventilation. The right ventricle doesn't really love positive pressure ventilation in many instances. It does decrease preload, and I have that illustrated here by the blue and white arrowheads. You can imagine that positive pressure inside the chest is going to decrease the venous return from the SVC and the IVC. But the other thing that it does is look at that little inset that's supposed to be alveoli being all distended by the positive pressure. And you can imagine that crimping little arterioles throughout the pulmonary vasculature. All of that crimped, increased pulmonary vascular resistance is going to lead to an increase in afterload on the right ventricle. Now, conversely, the left ventricle is going to have a decrease in preload because you have a decrease on the right side. You're going to have a decrease on how much blood flow is getting over to the left side. So you have a decrease in preload on the left side, which often it likes because often the patients are volume overloaded. but it also decreases afterload. And this is a key distinction. Positive pressure decreases afterload on the left side. And what it does is it decreases that transmural pressure. And I have that illustrated there between the red arrows and the black arrows being the positive pressure in this situation. So you can imagine it decreases the transmural pressure, decreases afterload, and the left ventricle in general usually likes that. If you're doing all of these things and the patient's not getting better, you probably need to be thinking about mechanical circulatory support. The intra-aortic balloon pump is really falling out of favor. It doesn't offer a whole lot. The studies haven't shown a lot of benefit. Impellas, we've got them there in the middle. We use them a lot at my center. Unfortunately, they just don't do quite as much as we want them to, but there's probably a patient population that will benefit. And then ECMO is ever growing. We have a patient here who's peripherally cannulated for VA ECMO. If you are at a center that does not do mechanical circulatory support and you have a deteriorating cardiogenic shock patient, be thinking about how you're going to get them to a center that does offer MCS, because this is the next step for that patient who's not responding to your appropriate medical therapies. And so to end this up, I'm just going to put it all together in a little algorithm here. The most important thing we have to do with cardiogenic shock is recognize the problem. We have to recognize what we're dealing with, and it can be challenging in the emergency department. And so I advocate optimizing their preload. Think about them being volume responsive, recognizing limitations therein. Small boluses may be indicated, but they also might need diuresis, which is why determining their volume status can be so challenging, but also so important. Contractility, we need to reperfuse the patients who need reperfusion. That's one of the most important things that we do in the emergency department, recognizing these patients and getting them to the appropriate care. Use norepinephrine if they're hypotensive, vasopressin, dobutamine, and then epinephrine is what I recommend for your algorithm for supporting their blood pressure. And then for afterload, remember that positive pressure ventilation will decrease their left ventricular afterload. They like that, but it can increase it on the right side. And the vasodilation may be helpful if the patient's not hypotensive, like using the dobutamine. We can start with that as our first line agent. So with that, I will stop there. Thank you all so much for your attention. I really appreciate it.
Wow, Dr. Wilcox, thank you so much for that spectacular approach to acute cardiogenic shock. It's incredible how you broke that down to be so manageable, such a nuanced topic. Really amazing. Thank you.